Assalamu alaikum students. In this lecture we will discuss about the most important topic regarding the clinical practice as well as examination point of view. Acute coronary syndrome, also known as myocardial infarction. It is an acute ischemic necrosis of myocardial muscle secondary to the occlusion of coronary vessels. Students, yes, what is myocardial infarction and what is the acute coronary syndrome? What are the types? And what are the criteria of diagnosis of MI? Similarly, we will discuss about worst prognostic factors, and we will discuss about general signs and symptoms of MI, and we will discuss about symptoms which are given in scenarios in exams. Okay, similarly we will discuss about complications of MI, and we will also discuss investigations which are required for diagnosis, and in the last we will discuss about management. So let's start the lecture. It is ischemic necrosis of myocardial cells. Why there is ischemic necrosis? Ischemic necrosis because there is decreased supply of blood secondary to occlusion of one or more coronary vessels. You know that the myocardial muscle is supplied by coronary vessels, so occlusion of these vessels can cause the ischemia of myocardial cells. As a result, there will be necrosis. So this is the myocardial infarction. Now, what is the acute coronary syndrome? Acute coronary syndrome is a condition in which there is when the unstable angina plus MI. Okay, similarly we can also say that when there is new onset of angina with myocardial necrosis, this is also a acute coronary syndrome. Similarly, increase in angina severity, it is also known as acute coronary syndrome, which is also known as crescendo angina. Okay, so now we will discuss about types of myocardial infarction. So what are the types? There are mainly two types of MI. First one is non-stem MI, which is non-ST elevation MI, and stem MI, which is ST elevation MI. In non-ST elevation MI, there is partial occlusion of coronary vessels. Okay, and in ST elevation MI, there is complete occlusion. Okay, when there is complete occlusion of myocardial vessel, the supply is totally occluded, and that there is transmural infarction. Hold the length and the width of myocardium is affected and it is ischemic. This is transmural infarct. And in non-ST elevation MI, there is partial occlusion and there is subendocardial infarction. Okay, these are the two main types of MI. Now we will discuss about criteria of acute MI. Okay, what are the criteria to diagnose acute MI? So first one is increase in biomarkers. So what are the biomarkers? Biomarkers are those chemicals which are released from the myocardial cell secondary to the damage. When the cell is damaged, myocardial cell is damaged, the chemicals like troponins, okay, and many enzymes like LDH will release from the cell and it is increased in the circulation. So these are the biomarkers. So increase in biomarkers which with at least increase any of following symptoms. Biomarker with following any symptoms. What are the symptoms? First symptom which should be there will be symptoms of ischemia. We'll discuss afterward what are the symptoms of ischemia. And there should be new ST elevation. Okay, new ST elevation or ST segment change or new left bundle branch block. Okay, this was second one. The third one is pathological Q waves. Okay, and there will be imaging. When we do imaging, i.e. echocardiogram, we will see new variable myocardial loss. Okay, new variable myocardial loss. This we will see in imaging. Similarly, we will see new regional wall motion abnormality. Similarly, intracoronary thrombus. So these are the symptoms and the investigation points which we will see. These are required for the diagnosis of acute MI. So now we will discuss about what are the worst prognostic factors. Worst prognostic factors are a rapid change in ECG, a raised troponin. When troponin is raised too much, this is worst prognostic factor. Similarly, recurrent troponin, recurrent ischemia, and arrhythmia. When there is arrhythmia secondary to the MI, it is worst prognostic factor. Similarly, hemodynamic complications. Hemodynamic complication means the hemodynamic complications. We will discuss about general signs and symptoms. General signs and symptoms are pain. First one is pain. The pain is more severe and long lasting than angina. Anginal pain is acute and it is not long lasting and it is decrease on resting, but the pain of MI is not decrease on resting. Okay, similarly there will be chest pain, pain around chest, throat, and there will be radiation of the pain. Pain will be radiated to the arms and jaw. Okay, this is the main symptoms of MI. Other symptoms are breathlessness. Breathlessness. Why breathlessness? Because when the fluid is accumulated in the lungs, the myocardial is damaged, the heart is unable to pump the blood. The blood will accumulate it in the lungs, and the due to backflow of the blood, there will be decrease in ventilation, so there will be breathlessness. Similarly, there is collapse due to decrease in blood supply to the brain. Similarly, there will be nausea and vomiting. Similarly, there is sympathetic activation, because the patient is too much in stress, there is symptoms of tachycardia and sweating. Okay guys, and there will be vagal activation also, which cause vomiting and bradycardia. Okay guys, now we will discuss the signs of myocardial dysfunctions. Sign of myocardial dysfunction. What are the signs when the myocardium is dysfunctional? So there will be increase JVP will be raised. Okay, there will be basal crepes at lungs. Similarly, there will be third heart sound S3, and there will be quiet first heart sound would be quiet. Okay, there will be hypotension and oliguria. These are the main signs due to myocardial dysfunction. Okay, there also a cold peripheries. The hands, the foot will be cold. This is also a sign of myocardial dysfunction. Now we will discuss about complications of MI. What are the main complications? For this, we can memorize a mnemonic, which is RAS dream. Okay, RAS dream, it means that R means rupture of septum and valves. Okay, A means aneurysm. S means septal damage. D means Dressler syndrome. Means embolism. There is a chance of embolism of any thrombus in the myocardium. Similarly, there is a chance of arrhythmias, and M means mitral regurgitations. Okay, we will discuss about Dressler syndrome. What is Dressler syndrome? Dressler syndrome is a condition in which, when there is MI, damage of the myocardium, there is inflammation of other valve of other layer of heart, which cause the symptoms of fever, pericarditis, pleurisy. After week of MI. So Dressler syndrome is a syndrome in which there is inflammation of heart valve and heart endocardium, pericardium. Okay, and there is a sign of pericarditis. Okay, and there will be fever, pericarditis, after week to month or after MI. Okay, this is called Dressler syndrome. So syndrome we give aspirin and NSAIDs with glucocorticoids. Okay, these are the treatment options for the Dressler syndromes. Okay, there are also chance of ventricular remodeling, ventricular remodeling secondary to MI. Okay, now we will discuss about investigations of MI. Investigations of a patient with MI. First and most important investigation is ECG. Then we will measure biomarkers, then baseline investigations. Similarly, we will do radiography, and then echo and coronary angiography. So what will be ECG? There will be sequence of events which occur as a result of MI, and these can be traced on ECG. So for this you should remember a mnemonic which is SRQT. This means first ECG change will be ST segment elevation. Okay, first will be ST segment elevation of specific leads. Okay, accordingly. Okay, specifically accordingly there will be ST elevation. Okay, then second will be R. There will be decrease in size of R wave. Okay, then there will be Q wave. Then there will be T wave inversion. Okay, these are the ECG changes. So as we have discussed that there are two type of ECG changes. One is ST elevation and second one is non-ST elevation MI. ST elevation MI, there will be ST depression. Okay, and there will be T wave inversion and ST depression with R wave having decrease in height. Now we will discuss about the leads of the ECG and its relation with the valve of heart. So for anterior septal valve, the ECG tracing will be seen on lead 1 to lead 4. Okay, similarly for anterior lateral wall of heart, there will be changes on lead 5, V5, V6, AVL and lead 1. Okay, in inferior wall MI, the ECG changes will be in lead 2, lead 3 and AVF. Are the biomarkers of MI. The most important biomarker is troponin. Okay, troponin, the troponin will rise from 3 to 6 hour, and it will be peak in 36 hour. Okay, and it will be remain at peak till 2 weeks. And another biomarker is CKMB. CKMB will increase for 2 to 6 hours at peak, and then after 24 hours it will decrease to baseline. So after 24 hours it will reach at baseline. So CKMB is used for reinfarction. If there is a chance of reinfarction or the suspicion of reinfarction, we will do CKMB. Okay, creatinine kinase. Okay, these are the biomarkers. Now we will do baseline investigations. The baseline investigations are ESR. As there is inflammation and too much acute reactions, so there will be acute phase proteins will be raised, so there will increase in ESR, C reactive protein, and leukocytosis will be there. So these all are raised. Similarly, lipids will also be raised. Okay, these are baseline investigations. We will also do radiography. In radiography there will be pulmonary edema. Okay, you can see the pulmonary edema. The cardiomegaly may be present. Okay, now we can also do echocardiography, which is done in order to assess the functions of ventricles. Okay, assess function of ventricles and detect the complications. Okay, we will do echocardiography, and at the last we can also do coronary angiography to see are the vessels which are occluded. So these are the main investigations which we will offer to patient with MI. Okay, now we will discuss about the management of MI. When a patient comes to you in emergency management of acute coronary syndrome, we should admit the patient. First of all, then we will assess clinically by doing ECG and troponins. Similarly, at the same time we will give oxygen, morphine for the pain, oxygen for decrease in ventilation. As there is pulmonary edema and there is decrease in ventilation, so we will give oxygen and we will give morphine for the pain. Similarly, we will monitor are the vitals are monitored, and we will give aspirin. We will give beta blockers, and we will give opiates for pain, and we will also give antiemetics for vomiting. Okay, then we will see the ECG. If ECG shows ST segment changes, okay, ST segment elevation or bundle branch block, we will go for reperfusion therapy. What is reperfusion therapy? In reperfusion therapy, we will do percutaneous intervention. Open the occluded occluded vessels, coronary vessels under the radiography guidance, okay, percutaneously. Okay, this is the percutaneous coronary intervention. This is the treatment of choice in first 12 hours. Sorry, first 120 minutes means 2 hours. First 2 hours, this is the treatment of choice. If it is not feasible in first 120 minutes, then we will go for thrombolysis. In thrombolysis, we will give IV fondaparinux, low molecular weight heparin, okay, tenecteplase to dissolve the thrombus, okay. And if it is if a PCI is feasible within 12 hours, then we also do PCI also, okay. Now other treatment options are antithrombotic therapy, which are aspirin, efzimab, tirofiban. These are the antithrombotic. They are started in first 12 hours and continue indefinitely, okay. These are the antithrombotic therapy. Now we also give anticoagulants. Anticoagulants are given up to 8 days, okay. These are unfriction heparin, low molecular weight heparin, okay, and enoxaparin. This is usually given in non-stem MI, non-ST elevation MI, okay. If there is heparin induced thrombocytopenia, then we will give fondaparinux or warfarin, okay. We will also give anti-anginal drugs also given. These are sublingual nitrates, IV nitrates, beta blockers, and calcium channel blockers, okay. These are given if there is persistent chest pain, okay. ACE inhibitors, okay, for long term use, as these drugs, ACE inhibitors, decreases the ventricular remodeling, okay, so we will give ACE inhibitor. Similarly, we will give spironolactone. This drug also decrease the ventricular remodeling. We will give statins. We will advise patient to stop smoking if he or she is smoking. Similarly, we will give dietary advices and exercise advices. We will do rehabilitation therapy, and when the symptoms are controlled, we do coronary artery bypass surgery, okay. So this is all about myocardial infarction. Thanks for watching.